And we're live. Sammy, how are you doing?
I am excellent. It's so good to see you. How are you?
I'm doing. I feel like you should be a co-host on this show. Not only are you here in the feed all the time, a big supporter. You send us great guests, and of course, you have a return invitation anytime you want. So, hey, we may have to move you up to the co-host at some point, but for now, we'll just take you as is. So, what are we talking about today, Sammy?
Well, we are going to engage for our audience on some conversations that we've had about, social and or just inequalities related to a lot of what I call like the social impact, but just really the lifestyle impact in our cancer population, and how this conversation started with all of the great work you all are doing with like the Cancer Equity Project made me realize that from my background as an oncology exercise professional, which is 20 years this month that I've been doing this work, and seeing how much evidence has come forward where when I started, we didn't talk about exercise, we didn't talk about activity. We were like, you just go off and get treatment, take care
Yes.
of yourself, see you later. To now, we're coming forward to say exercise is really recommended as part of the cancer treatment plan, but still understanding that the delivery or the implementation for that isn't happening because often there's this bias over which patients we think are going to be the most interested in these interventions. And I struggle with that. I shared a story with you, Sharon, and I have a great relationship with so many physicians, so many
Hmm.
surgeons, so many medical professionals. And I remember a recent conversation I had with a surgeon, and I was telling him about this new research in prehab exercises for esophageal cancer. And he was like, well, that's great. But, I think only the patients at this one, particular location he did surgery, which is sort of our more affluent,
Hmm.
more white, more sort of suburban health system location would be interested. But the patients at the other place that he did most of his surgeries, which is our urban minority location, they wouldn't be interested. And I've heard this so many times in my career. And I will say, I do appreciate the relationships that I have with these physicians that they'll tell it to me, they'll tell me these things, that these comments, because it allowed me to say, but wait a second, why do you think that?
Hmm.
Well, and so it was an opportunity for me to address the bias. So I do really appreciate that, but it continues to be a challenge that we are
Yeah.
seeing in how these patients, it affects their mortality, not
Yeah.
just prevention, but really how they're going to do during and after surgery. Getting to jobs. This is usually a physically active workforce. If they can't
Hmm.
work, how do they pay their bills? And we know
Right.
that financial toxicity is one of the biggest concerns. So it really allowed me to kind of take a step back and think, okay, it's great that we have recommendations, but if we don't implement, what are we doing? And so that was where this conversation, really started.
Well, first, I just want to say this, Sammy. Well, first of all, 20 years in this space is amazing. And so I thank you for the good work you're doing. I'm certainly glad you're in my life because you've really turned me on to the strength training because the doctors really did mention that.
Yeah.
But I will say I went to my appointment last week with my regular doctor, and he was like, "Hey, are you exercising?" I said, "Yes," and I'm also adding strength training, and he was very happy and very pleased with that. And I'm just thinking to myself, not having, people like Sarah who said, "Hey, we're going to attack this problem." I'm beginning to see why the outcomes are so difficult and so different
Mhm.
for underrepresented groups because the information is just not there. And I'm so glad that we have, soldiers like yourself, like what we're doing here at Cancer Equity Project, like Sarah's vision to really bring this to the forefront, right? Bring this conversation forward. And I'm so happy with our team too, because they're also finding information and bringing it forward. So I feel confident that the work that we're doing and we're doing together, people like
Mhm.
yourself, is going to really have an impact. Even if it's just on a few lives, that's plenty. That's lives that will be altered. But of course, we're expecting greater impact than that. So please continue.
Well, I think it's, one of the things that we have struggled with, exercise oncology researchers, there's so many studies now on safety and efficacy and outcomes in really diverse populations, whether that's metastatic, um, whether that's, preventing some of our types of cancer that we know are not necessarily obesity, but they're other lifestyle related cancer diagnoses. But here's the challenge, and I think the next space, it's great that we have the evidence,
Hmm.
but it's how do we implement? So as an exercise professional, we might say, well, supervised exercise would be the best place for you to be. And here's what I know: we don't have enough workforce. If you're a busy working parent, you don't know if you have the financial means to pay a copay at rehab, even if you have great insurance, or the time, or hire a personal trainer or a certified exercise professional. We need to really think through the lens of how do we implement it, right? And it's like
Hmm.
we did last time. And Sharon, that I'm going to make you do something. I tell everyone, okay, so everyone sitting here watching, I want you to do this exercise as I'm talking. It's called a heel, or called a soleus push-up. It's a really fancy name for a heel lift. Okay, so lifting up your heels, putting them back down, lifting up your heels. I want you to keep doing this. So how many of the people in the audience, Sharon, this, diabetes, type 2 diabetes, a significant health crisis, right? How do
Yes.
we manage our diabetes? Well, people are like, I eat less carbs, I take a medicine. This exercise, these soleus push-ups, hopefully you're still doing. If you do these at your desk, for those of you that are working, if you're sedentary, maybe not, feeling really fit or active right now, and you keep doing these types of exercise, you will actually lower your blood glucose through this particular exercise just by doing it at your desk. So to
Wow.
me,
Lifting your heels and putting it back down.
truly,
Wow.
because
Wow.
that particular muscle, and you can stop if you want to, but that particular muscle, the soleus, is a very fatigue proof muscle. But so you can do it all day, but it's very effective. So because you're using the muscle, your body's uptaking that glucose, right? Well, guess what? Managing blood sugar is important for all of us. But it's like these strategies that we know and we see in research, let's apply them. Let's give them to those kinds of, through conversation. How great would it be if your physician was like, hey, try these heel lifts with me while we talk? Because patients will feel also successful, right? And
Yes.
rather than evaluate someone in a chair, let's evaluate them moving. So these are some of my strategies and my thoughts around simplicity. Simplicity would be ideal.
And it's so simple, but you said how cool would it be if your doctor said that to you, right? You know how cool it would be? It would feel like they actually care. That's how it would
Yeah.
be. It's even beyond just telling me about the exercise. It's me thinking, okay, you're giving me tools, you're actually helping me. And if
Right.
I think, and think about it mentally, Sammy, if I, the patient, think you're trying to help me, guess what?
Hmm.
I'm going to try to help myself even more. But if I feel like I'm just another number in the 10 minutes you have for me, it's going to really affect my outcome. So, Peter says we have to get clinicians to stop and just think about these unconscious biases. And I'm hoping that through our education program, through our Seek, color
Hmm.
certificate program, that this is what we're trying to bring to the forefront. Like this, we're not saying you are racist or prejudiced. We're just saying it's unconscious. You mentioned obesity, right? And obesity
Oh
is
yeah.
usually tagged with Black people, or Hispanic people. Again,
Hmm.
it's just an unconscious bias. But like you would say, the doctor would say, maybe not that group, but this other group over here might be the ones that would
Right.
benefit, and it's kind of sad.
Well, and I think also, we have this mindset of also, we tend to maybe not want to talk about topics. We're not comfortable talking about, maybe we're uncomfortable with our own weight. Maybe we're not meeting our own exercise recommendations. 25% of adults in the world, in our more, progressive nations, we're not talking our, very poor nations across the world, but United States, 25% of adults, all of us, meet physical activity recommendations of aerobic and strength every week. So if
Mm,
you're not meeting them and you're going to tell someone else to, I think that's a part of the challenge of the conversation. Or we don't want people to feel guilty that they caused their cancer. Yet
right,
we're okay talking about tobacco cessation. And many times we see lung cancer in non-smokers, right?
right, right.
And then we don't talk about lifestyle or exercise in a lung cancer patient, when in actuality, we really need to keep them strong because they need the muscle mass to be able to go through some of the treatments. And there's different side effects that happen. So at any rate, I think it's almost like maybe I shouldn't talk about it. It's not my job. And maybe I'm uncomfortable with my weight, so I don't want to talk about somebody else's. I don't know.
You
I think that
know,
I see that would be
you make a
interesting.
good point with that because you make a very good point about that with the doctor feeling uncomfortable about their own, maybe their own exercise journey. Because I've actually heard a doctor say that to me, who was, was quite overweight and was asking me about my routine. This is years ago, but I can see, I could actually see how uncomfortable that could be. Here's a question for you, Sammy. What do you think of Ozempic and these meds
Mm.
as a quick fix for obesity? And maybe talk about whether any risk outweigh the benefits of weight loss, especially when you're recovering from a cancer diagnosis. Good question.
I think that's a great question. I think from an obesity perspective, there is definitely relevance for a lot of the medications, that can be prescribed to help. But I think sometimes, if we look at obesity as sort of the end problem, we're forgetting a lot of the things along the way. So I think that if we're going to, address obesity through a medical lens for the prescription, it needs to be with an obesity medicine physician. And
Hmm.
because then the generalization is going to be, it's going to be more than just we're going to give you a medicine. It's almost like I know a lot of times our oncologists or our providers in oncology will give, antidepressant or anti-anxiety medication. And I think it's very appropriate in a lot of settings. But if it's just sort of part of the care plan, then who kind of manages that when the person is not in treatment? And
Right.
so I think that sometimes we need to remember what our scope is, but the role of obesity medicine in conjunction with cancer is very relevant. And because a lot of our cancer survivors do gain weight, especially body fat, it's something that they're very concerned with. We're concerned about recurrence, et cetera. But I think from obesity, there's no quick fix.
Yeah.
So that's kind of my lens. My physicians might have different opinions, but I think that we need to be careful about just giving another medication for sure.
Do you think there's a future? You know how you have an integrative oncologist, right? As part of your care plan.
Mhm.
Do you think there's a future for, like you'd say, obesity oncologist, obesity doctor? I mean,
Yeah,
because it's, or you don't
it's a
see
hard
that
one. You know what I would love to see, and I think there's a very, very bright future, is sort of this lifestyle medicine for
coming.
cancer lens, because the pillars of lifestyle medicine include nutrition and exercise and social connectedness, sleep, stress management, and risky behaviors. Well, all of those tee up to improve obesity. Right.
That's
So
true.
I think that one of the things that I've learned about delivering community-based programs or delivering healthcare-based programs around obesity, we use obesity as the way to get people in the door. And then we teach them how to read food labels, how to incorporate exercise, improve their sleep. And although we're not talking about their weight, we're teaching them habits. And I think that is what we're seeing in lifestyle medicine. And I think that
Mhm.
will engage more patients. Also, because patients are like, I don't want to just be focused on obesity. I want to live better. But
Right.
again, bringing up biases, a lot of these things aren't covered by insurance. So who has the access to those? People that have extra cash. And that alone is a significant challenge in my mind, and where I think we need to think very strategically about these initiatives. Deliver it simple. So I always tell people, if you're busy, think about how busy you are. And then I'm going to talk to you about exercise and what can you do in 10 minutes. That's what you
Mhm.
tell your patients.
Mhm.
And that for people, I think is very doable because everybody is busy. And that
Right.
makes more sense.
Good point. Okay, Peter has a question. What role do you
Yep.
think nurses and APPs have in starting to address some of the racial disparities in integrative cancer care and our cancer prevention strategies?
I think it's a great question. I think the biggest thing that we need to do is we need to really remember every patient that we see wants to know how to live their best life after a cancer diagnosis. And
Right.
it does not matter where they come from. And they could be someone that comes from a tremendous amount of wealth, which sometimes can bring other challenges to the table, whether that's a different aspect of risky behavior, right? So I
Right.
think that we need to look at the lens of like every single patient needs to be given this information and education in a manner that is simple to uptake, not well, now you have to go to see this special dietitian or you have to do this special cancer exercise class. I think if we looked at that, everybody is equal, we would get
Mhm.
so much further faster. And in a conversation I had earlier, and Sarah was included in, I think sometimes we forget if we talk about it or we don't remember, if we talk about it, it's also self-care.
Right.
Because now I'm engaging with you about exercise. I'm reinforcing my habits and in a good way. So I think that there's a lens there that we can also help our medical community with as well.
Okay, next question. Why are things like exercise, wellness, and weight management through cancer especially important in minority populations? I think you just said it's important in all populations, but I'd love to hear
True.
your take on that.
No, it's a great question. I think what we're starting to see is in a lot of our patients, like, and this tends to happen a lot in minorities, this is a population because they are often marginalized and often have a lot of other barriers that are practical, like where am I going to, where do I have enough dollars to pay for my groceries? Or I live in a food desert. I don't have reliable transportation or any transportation. That there is a acute amount of chronic stress that
Yeah.
is in present in that population, and that chronic stress leads to a lot of other challenges that we see kind of related to chronic diseases such as cancer. So high inflammation tends to create more obesity. Well,
Hmm.
more obesity is linked to 13 kinds of cancer that we know, but other chronic diseases, cardiovascular disease, diabetes, stroke, etc. So I think what we're seeing, it's not causation, it's correlation. And that
Hmm.
when we look at certain populations that have these ongoing stressors, they tend to have different lifestyle habits, but they tend to have less healthy bodies and minds. And so I think we need to be careful about being, it's definitely, a Black concern or Hispanic concern and sort of look at it from what these populations are facing in their day to day as the biggest challenge.
That's a really good point, right? It's almost holistic in a bad way. When I say the word holistic here, it's in a bad
Yeah,
way, but it is. It's almost like, okay, so these things add stress, and then stress, goes in and affects the body in ways that, like you said, it's not just cancer, it's all these other things that are in the Black community, like diabetes, which is pretty high
right,
there. And of course, we know the number one killer is still heart. So,
right.
yeah, yep. Which is better for cancer prevention, strength or cardio?
Uh, neither, both. So interestingly, so I will tell you the one thing that I want everybody to kind of realize is like cardiovascular exercise is just kind of like activities of daily living done at a higher intensity.
Hmm.
So if someone is really, really active in their day, they're walking or maybe doing a lot of things around their house or, making meals and standing in the kitchen or doing laundry, I tend to think that they need to make sure that they're meeting strength guidelines where most people default to aerobic and walking because we don't have to think. I don't have to worry
Right.
about how much to do. I don't, what's my form, whatever. So, from a cancer prevention and survivorship, as well as during treatment, the recommendations are 150 minutes of moderate physical activity per week, right? Which means you should be challenged, but not. I tell people you should be able to sing lightly and talk, but you don't want to be basically having a conversation like you and I are here, Sharon. Like it should be uncomfortable. But it
Right.
includes twice a week of resistance training because that muscle, as we mentioned, is
Hmm.
important for diabetes. It's important for cardiovascular disease and brain health. So you really should be doing both. But I start with people doing strength because most people default to aerobic, and we women tend to think we just need to burn a whole lot of calories. And I
Yeah, I
get
mean
it.
that's until we had our show together. I mean, that's where I was focusing on. I mean, my daily
Yeah.
walk and jogs, but adding the strength piece has had a lot of extra benefits, like some more toned arms. So I'm liking
Oh,
that.
yeah. Well, and honestly, I mean, muscle mass is like your muscles and organ system, right? So diabetes, but also like your brain. But
Yeah.
here's the sweet spot. We as women start losing muscle at the age of 30, about a half a pound per year. It's one of the reasons our metabolism shifts. It's one of the reasons that women have to start watching what they eat a little bit earlier, right? Because we have less general metabolism.
Hmm.
So, one of the other reasons that muscle is so important for us ladies, not only are we a little toned, more toned, a little firmer, smaller, muscle takes up less space. We burn calories while we're sitting here having a conversation, right? The more muscle that we have.
Oh,
So you go walk or run a mile, you burn calories when you do it, but then when you're done, you're done. If you put on muscle mass, you burn calories at rest, like when you sleep or when you're hanging out with family or watching a movie or driving in your car. So it's actually kind of the pixie dust to weight management as muscle, to be honest.
Awesome.
Yeah.
Ilana has a question. She says, where
Mm.
do clinicians get the training to incorporate exercise into their oncology treatment plan, or do they get the training?
That's a great question. Honestly, I think, there are certifications to get cancer exercise or oncology exercise training and education. I will tell you, I think for busy clinicians, what I really recommend, even though the guidelines from like ASCO recommend that oncologists kind of prescribe or encourage exercise, I can't imagine oncologists can really sit down with a patient and be like, here's how you squat.
Right.
Here's your exercise program. So what I usually tell like my clinicians is, I just need you to green light it and bring it up and ask the question. And then we need to refer to someone in the field who can take that time with these patients and caregivers and help them to not only come up with a movement plan, but empower them to feel confident doing it. Because
Mhm.
I think it's like my doctor. I want my doctor to talk about doctor things and
Right.
make sure that they're, looking kind of that head to toe and then refer over to the other partner on that. But the workforce is growing in exercise oncology. And so I think we will see more of these professionals in our cancer centers in the coming years.
I agree. I
I hope.
think my last three appointments in the oncology space, they've asked me about my exercise habit. So I think the message is getting out there that this is a big part and it should be emphasized. And they were asking me how often am I doing that? So I think that's getting around. And that's very, very encouraging. Very encouraging. Sarah
Definitely.
says, do underrepresented communities benefit from these kinds of treatments? And I guess what she's talking about, maybe, I don't know if it's the exercise or,
Or just lifestyle medicine,
yeah.
maybe.
Hmm.
You know what? I will say this. I think that if we can bring lifestyle medicine into the communities where people live and work, actually, we've had a lot of success bringing in exercise programs to a lot of churches in urban areas because that's a supportive community, tends to be a great space. So, over my 20 years, I have been at many churches and taught exercise classes and done support groups and been welcomed into this space where people are comfortable with. And then I will tell you something really amazing. You almost only have to go once or twice because then the community is very immersed and engaged and empowered to take care of those that they serve. And so through
Right.
the course of 20 years, some of the best success that we've seen in delivering programs into the community has been going into where people live and where they go and socialize, which has often tended to be places like church. And I think that that should be okay. And it
Hmm.
isn't about me and my home, it's about how do I deliver it there. So I think that, that also creates social connectedness, which is another key lifestyle behavior and behavior strategy. So I think that we should think outside the box. Everything shouldn't have to be at the hospital for sure. I think that would be important.
That speaks to the biases again, the unconscious bias, because you said, right, you go to churches, right, which is, in African American community, church is huge. It's a big part of
Hmm.
social life. It's a big part of community, a big part of care. And I mean, as for, I guess, other communities as well. But here's what you're saying, once you get in and you empower these people, they'll take it over. It's just getting the information I mean, that's what I think is lacking, is not giving not giving people a chance,
Right.
making a judgment call, right? Just
Yes.
based on how someone may look, and not
Right.
giving them a chance. And I think that's what people like yourself and what we at Cancer Equity Project is trying to just to bring to the forefront. Like, listen, give people a chance, put information out there, educate these healthcare clinicians, and then maybe follow up, and then have folks like yourself alongside us, just keep repeating the same thing, like bring the information forward.
Right.
Now, for some, what can someone do, right? Like the last time you were here, like we just told us about the heal,
Yep.
which is really good. Which was again something new I learned today because I'm at my chair a lot right here. So I'm going to be doing some healings. But
Yes.
what else can we do that's a simple and get us, as a start? What do
Yeah.
you recommend before we leave?
Well, I'm going to back up here. I know, and I'm in a hotel today because we're traveling. So it's kind of like, all right, so I'm going to be sitting here. I just want you just to start by marching, right? Sit up really
Hmm.
straight. You have to sit up straight to march. Try to pick up your knees as high as you can. Bring up those big arms. And then like you realize like, okay, my heart rate's kind of coming up. Now you're going to plant your feet and just stand up and then sit back down. And now let's stand up and out our arms and sit back down. And so by doing these kinds of things, even if you're on a meeting and you just move my legs, nobody can really tell I'm moving my legs, right?
Right,
But by
right.
doing these sort of things, although people say, well, that's aerobic, if you do seated march vigorously, it's actually more strength because you actually have to, utilize your muscles in a different way. There's also great YouTubes. I have nothing against doing YouTubes, and they don't have to be cancer. They don't have to be a specific thing. I think we need to start with where we are and start
Yeah.
with just a few minutes a day. One of my favorite things I tell people for sleep strategy, it's not about how you always go to bed, it's also how you wake up. So in the
Mm.
morning, you should get sunlight and 1 minute of movement. So I challenge you, everybody, tomorrow morning when you get up, try to get sunlight. If you can't get sunlight, still flick those lights on because it kind of resets your circadian rhythm, prepares you to go to bed this following night. But get a minute of movement. Get
Mm.
kind of something countertop push-ups, standing in your kitchen and doing squats. I do that all the time. Or just take a walk around your house, kind of things make a big, big difference as well.
Well, I have to attest to the countertop push-ups. Those have just that's where I started, when we talked and graduated from there. But countertop push-ups, your bathroom sink, push-ups. I mean, just any surface where you can push against. It's amazing. All right, I think we may take one or two more, and then we're
Okay,
gonna have you give us a closing statement, Sammy.
sure.
Would love to see a conference on integrative medicine strategies in cancer. Are there any regular conferences in the area for clinicians? That's true. It's
There
still
is
not.
the Society, SIO, the Society of Integrative Oncology. They're meeting in Banff this year, Banff, Vancouver in September. But I think the thing to think about is integrative oncology is largely things like acupuncture or herbal versus thinking about lifestyle medicine, which is kind of these pillars of really looking at nutrition, very plant forward nutrition, unprocessed or minimally processed nutrition. So it doesn't even have to be all plants, but just thinking about process. The American College of Lifestyle Medicine, which is an organization I'm heavily involved with, has a conference every year, not just cancer, but is looking at all the chronic diseases. But everything ties together. The lifestyle medicine pillars are the same. We just need to think about application. But integrative oncology tends to be a bit more complementary than lifestyle medicine. There's not right or wrong, there's room for both. One of the challenges with integrative oncology is largely there is a cost because acupuncture does have a cost. Herbs do have a cost. Massage does have a cost. Not that that's bad, but I think it's harder to figure out how to deliver that well in specific populations. So I think that would be something that's kind of just a lens to think about when we're recommending everybody should get acupuncture for neuropathy. Maybe, but
Mhm.
until we have a delivery, I'm really hesitant to make that kind of blanket approach. Yeah.
Peter says, thank you, Sammy, for all your hard work getting the message out. And Sammy, this is Tea Talk, so we like to end on something that's going to stimulate our T cells, right? So
Yep.
as I sit back in my chair to listen to your final words, what can you leave our audience with today that will stimulate our T cells?
I think I will say this. I think that one of the things that we really forget, we do connectedness, good social connectedness is one of our keys for lifestyle medicine. And although we're really accessible, right? It's like having these conversations with people that it's like you feel like you're not like the only unicorn in the room at the table of you bring up this idea to silence. It's so empowering. And so what I really tell people is build up your arsenal and community, right? With these kinds of people, make them people your friends. Like as soon as I can get a hold of someone's cell phone number, I keep it because you never know when I'm going to need a good conversation. But I encourage you today to take a moment, take what you've learned, deliver this information to somebody you think that may not be interested and see what their response is. Because
That's
I
it.
think we would be surprised and we open the conversation, people would say, I would love to hear more. Tell me more. How do I do that? And I think that's something that we should do more as well in conversation. That's how we deliver, and we share this over time. So, yeah,
That's a really
thank you.
good point. Really good point. And I will just say that is true, Sammy, because I posted a couple weeks ago. I got a phone call from my church about someone who was just recently diagnosed, newly diagnosed. It was a white woman, a friend of mine, and they wanted me to to just give her some words, right? So I took everything that I've been learning here about the exercise, about the diet change, about, you know, the herbs and the vegetables and all of that wonderful stuff. Today's actually her first appointment with her breast surgeon. And she was just so encouraged. And I'm so grateful that I had the knowledge, you know, and the opportunity. Yes, I had my own experience, which was pretty good, but I have all of this extra data working here at Cancer Equity Project and Total Health that I could share. And so you're right. I think if we would just pass on the information, for those of you who are watching or watching the replay, if we could just pass on the information and share with someone without any judgment and leave it there. So thank you, Sami. Until the next time, I know you're going to be on again. I'm not quite sure which date, but I'm sure you will be here. Thank you for all the work that you're doing, for the good work you're doing, and for all the referrals that you send to us. All right, folks.
Thanks for having
see you on Wednesday. Bye, everyone.
Bye, everybody.